So put me in the room with Dan Haller and a new patient in downtown Philadelphia, metastatic colon cancer. What are some of the key elements that you want to know before going in that room, and then what are some of the key elements that you're going to discuss? Or curative, non-curative, lines of therapy? How much do you get engaged in that first visit with that patient? And I know it depends on the patient, but put me in the room with you and mentor us.
Well, usually what I tell them is, what is most often done in the United States? And the answer to that is still FOLFOX bevacizumab. And I start there, and then I talk about the options in different directions of why you might choose FOLFIRI versus FOLFOX. And there are certainly patients who should not be getting oxaliplatin. And I think we're in a period of flux about the EGFR agents in first-line therapy, obviously used much less in the United States than in Western Europe. The other part I tell them is, for the biologic, I'm not always sure. If on a clinical trial, we always start every drug on the same day. But that's not real life. In fact, you can start the backbone of whatever chemotherapy you want and add the biologic on the next cycle or the cycle after that, rather than waiting to, for the test to come back.
Yeah. But let me start a little bit. I mean, I think what John's was getting at is, what is your goal of therapy, for instance? So you have a patient sitting in front of you, newly diagnosed metastatic disease, and we know some patients can be rendered free of disease with the option to be potentially cured. I mean, we kind of tell them we can cure you, but the likelihood of cure is not as high as we sometimes convey. But still, rendering patient free of disease is a goal.
8 bilobar liver lesions. Do you go in and tease the patient and say maybe, just maybe?
Yes, I do.
Me too.
Sometimes.
Anybody else?
You never know.
You never know.
Yeah,
we're wussy oncologists because that's a tough one, right?
Because the problem is
we might
really,
get them
Well,
to NED,
I'll say it's a reach. I'll say until I don't think we can do it, we're considering it an option.
No hard line in the sand.
And you never know.
Yeah.
I mean, as I said, you have seen dramatic responses, consistent disappearance of lesions, which will never grow back. Happens.
It's made it fun a little bit, is to be able to go in there with that little ray of hope.
John, when a patient comes in, particularly newly diagnosed, there are a lot of things that have to be covered. What it means to be a patient, what it means to be involved in the medical complex for the next, whatever number of months or years. The other thing is, people need to understand, and we need to understand it and convey it. People are really interested in therapy for 2 things: the average benefit and the extreme benefit. It's like buying the lottery ticket. This is like, you call it teasing. I would tend to say that's not the right word when you're dealing with someone's life. But people need to understand, and this may take a time, and often it's more than one visit. What's the average benefit? Is there a potential for an extreme, near cure or long-term control? And we'll see how it evolves. And then you also need to be aware of what's the chance of real harm. Until you can orient someone who, we think it's hard for us to appreciate this, hard for a general medical oncologist. Think how hard it is for a patient who may not, to go through, what are you talking about? An average benefit, an extreme benefit? My analogy, which I like, is, there's an average return and there's buying the lottery ticket. And I think that often helps people get oriented to a spectrum of options. And then there has to be a lot of trust, because you have a certain probability when you meet. You have a lot more information after your first restaging. You know how the patient's tolerated treatment. You know how well it's worked. And I think that ends up really being this continuum of information. And the rule in medical school is, if it's important, it gets repeated. And I think we need to realize that patients need to have information along a continuum. And if there's trust, I think it makes it a lot easier to make these decisions. While you have to have a framework and get oriented, a lot of this is the nuance of how you play the game once it started, not sort of your game plan just initially in theory for the average patient, because very few patients are average.
I really like what you're saying about acknowledging that this patient is now going to be part of our family, right? They're going to be, coming, you're going to get to know everybody, there's going to be emotional stress and all of that. And in an hour and a half visit, you know, it's really hard to cover all of that, and a patient and a caregiver and on the other side, how do they, you know, when we're talking about capecitabine versus pumps and ox versus Erie, and they're just, you know, what do you mean I'm going to die? So how much of that are you bringing into your initial visits, and is that really, should we be doing a better job of that as oncologists?
So I had an incredibly informative experience just about 3 months ago. A parent of one of my faculty was diagnosed with stage 3 colon cancer. So we had the discussion of the adjuvant therapy. I think I'm really good at that. And we talked a 2-hour meeting, and my junior colleague was in the room as an offspring, not as the doctor. And I learned later on that they had what does he mean by this? What does he mean by that? What does he mean by recurrence? And it's stunning how we're comfortable with a conversation that may not be getting through.
Well, and my wife's cancer, as you all know, was a really life-changing thing for me. It really caused me to see, you know, as a consumer, what it feels like to be coming in on that other side, and what you can hear.
So
and
what we do is we stage it. I say, we'll talk about this today, we'll talk about this next week, and more, the first discussion we have to have even is, should the primary be removed? Which is getting back to ground zero, because most patients come in with a data set they assume they know what's going to happen, and so sometimes you wind up spending time in the patient who presents with stage 4 disease and telling them we're not going to take your primary out now, for example. So we usually take months to get patients on board.
So staying up here high level,
But I like the staged approach, because I use it too. Because if you could, let's say you're in a palliative care, every patient wants to be cured. And, you know, just realizing, you know, this is not the goal anymore. The goal is to, and the words I use, is to keep you around in good quality of life as long as possible, using the least amount of treatment necessary to control the disease. And then you talk about KRAS, NRAS, BRAF, whatever, and then you talk about, it's impossible. It's such a flood of information which we potentially feel comfortable with, but for a patient, I think I really like the staged information, because patients do not need every little bit of detail that we've learned in, let's say, years and years, because they won't remember.
And it's not fair to expect. I mean, the viewers here are going to tune in for like a half hour to an hour, and then you saturate. And if you think that's something around the content you're familiar with, I mean, there's a point where patients and families, you can see, are approaching overload. And the issue, you know, much like, we don't want to turn into this caricature like a Gary Larson cartoon where the doctor's sort of talking and the family is just sort of like hearing, like, you know, verbiage that makes no sense. There are times as a physician, and you said, you know, patients or family, this is a privilege to get close to people and get to know them and be part of very important decisions. But part of that is realizing you have to stage the information. Sometimes you need to actually lead people and come to an important decision quickly if you really need to. When there isn't the time pressure, you need to recognize that and be able to empower patients to make the best decision for them. And generally after one or after the second visit, once people sort of learn and get comfortable with the process, I think a lot of these things fall into place actually fairly easily.
We do a lot of second opinion business. I mean, I bet half my patients I'm not the first oncologist that they've seen. And honestly, I go into that room, it's easier, right? They've already heard a lot, you know, you're not the messenger. You're going to shape the message. You're going to, and so they know already about ports and pumps and neuropathy, and you're just, you know, so you can give a much higher level message than it's that brand new patient deer in the headlights, you know, a week ago found out.
Except for the fact of what you have to, the disinformation you might have to
undo.
Yeah,
No,
which
it's
is
true.
which is a.
But I think we need to acknowledge
Totally.
that we
Most
do
of the heavy
only
lifting
one
is
kind
done
of
for us
disease,
already,
right?
right.
And we do a lot of second opinion business, so it's easy for us to be all know-it-all about this. But if we had to go into a breast cancer room and then a colon cancer room and then a leukemia, you know, we get it. This is hard, but you know, some of the ways that we try and make it better and share this. All right.
Sometimes one of the things I do with patients is say, you know, I can describe to you an average patient from an average clinical trial, but you know, you're not going to be that average patient. What's going to happen to you is going to happen, and we'll learn about that together. So as we do the treatment, we can add information. It's not a one-time deal. It's sequential.
And at some point along the way, are you talking lines of therapy, or do you just, I mean, is that part of the overall vision fairly early on, maybe not first visit, but in the first month or so? And we're going to do this, we're going to back off, or is that come up until the clinical scenario?
Well, of course, patients want to know what their calendar is going to look like over the next 6 months, and I'll say don't write anything in ink.
Yeah.
Use pencil, and we'll see where we are. And I think they typically go from landmark to landmark. The next scan, for example, or toxicities. I think. But most patients, after you've discussed what we're going to do now, want to know what are we going to do next, Doc?
What's next? When do we start? So let's start.